and she's going to be speaking on how to sustain the change. Stacia creates and delivers educational presentations for healthcare providers and for patients. And she's also is working on a project with a group of researchers exploring binge eating and some of the fundamental factors that are part of that. She has vast experience with a wide range of kids, teenagers, adults, First Nations, all in community research and health research. And she's here to share her thoughts with us today. So,
and clinical practice.
And clinical practice.
Primarily clinical practice. So thank you. Thank you and good morning. We're going to look at keeping the change this morning, and I mean, this is something you're familiar with, and if we consider that obesity is in fact a chronic condition and look at it from that perspective, then that requires us, from a conceptual perspective, to it suggests and almost imposes a certain set of frameworks, and one of the primary fundamental assumptions then is, if it is a chronic condition, if we want to look at it in those terms, then we cannot focus on weight loss as a primary goal. By definition, both from a health perspective, but also from a psychological perspective. Once I've met my goal, I'm done, right? That's where we see some of the back and forth yo-yoing there. So if we look at weight loss as an outcome of interventions, and clearly this will be consistent with, I'm sure, much of your perspectives, that obesity management is about health and well-being, right? And so the goal really is not then, if we want to reframe the goal, it's not about weight loss. The goal is about a healthy lifestyle, a balanced lifestyle, and the healthiest weight possible. What we want to do is refocus our patients away from weight loss. We want to look at long-term and sustainable goals. If the goal is weight loss, then weight regain is a failure. And when we look at the population of obese patients that we have, that we're working with, and one of the primary considerations, again, from my view, is the internal dynamic around weight in their body and that ongoing process. The other reason, or one of the other significant reasons why we should be focusing on lifestyle, healthiest weight, that sort of process, is because when we look at this population, the significantly overweight and obese population, we have very, very high levels of comorbidities. Psychological comorbidities, psychiatric comorbidities. So I understand that Dr. Stonehawker will be coming to speak to you next week about depression and anxiety, and that's a piece of it, but we also need to consider other mental health conditions. We need to consider ADHD. That's a significant comorbidity with a very high proportion of the population. The folks here at the Adult Weight Management Clinic, or the Edmonton Specialty Bariatric Clinic, I think is what they're calling themselves these days, tell us that depending on the cohort, they see 38% of folks with ADHD. And again, ADHD, a lot of significant chronic comorbidities there as well. Some research tells us that with this population, we see as much as a 70% comorbidity from a psychological perspective in terms of significant trauma histories. So 69%. And again, those numbers will change depending on the level of obesity and that and across populations. Nonetheless, that's a significant level of comorbidity that will have a significant impact on weight management and that kind of thing. And of course, up to, again, some populations, up to 30% of folks with, again, it depends, of course, on whose research you read, but up to 30% of folks with significant obesity concerns also have binge eating disorder, other sorts of eating disorders. And so, again, we're wanting to be focused not so much on the weight loss, but the things that will get us to that particular goal. So we know that success is individual, and it's very different for each individual, and how we may choose to define it for them. In consultation with them, we help them define it for themselves. So, if we consider the process of change, any number of perspectives. George Carlin, sadly, he's not around anymore. Thoreau, things don't change, we change. Emerson, everything you've missed, you've gained something else. Everything you gain, you lose something else. And so again, that question of balance and lifestyle. Viktor Frankl, I don't know if you're familiar with him, an Austrian psychiatrist. Spent time in the concentration camp during the Second World War. Brilliant fellow, developed a school of therapy, but came to some of his perspectives and some of his insights clearly from the perspective of that extreme situation. And of course, growth is the only evidence of life. And if we can frame change in these kinds of parameters, then that will support the change process for our patients. So that said, I thought what we could do this morning is just look at the entire change process from the perspective of our patients. And clearly, most of the patients that we see that come in for weight loss assistance, weight loss treatment, have tried many times, right? And so again, it's helpful to frame things in those terms as a process. We want to focus them away from some of their bad experiences, some of the challenges that they've had in the past. One of the other reasons is that, again, from a physical comorbidity perspective, a significant proportion of our obese patients are also at risk or have been diagnosed with type 2 diabetes. And so again, they're focusing on things like healthy lifestyle, managing medication, physical activity, and nutrition. So here's some of what our patients see. We speak to the question of change not being an on-off switch, but rather an ongoing process. And the image of the leaves there is to support the fact that if we wanted those leaves to change, we would have to know what's going to support that change, because some trees and plants change in response to temperature, and some trees and plants change in response to light conditions. So if we want our plant to change, we have to understand what's going to support that change from an underlying perspective. When we speak to this with our patients, that tends to be a bit of an, oh, I never thought of it from that perspective. And then we speak to them from the perspective of the trans-theoretical model of change, and that's been paraphrased and put up here for you in ways that they can understand. So the correlate, of course, of pre-contemplation is not even thinking about it, and it's framed in those terms. It seems to be, for many of our patients, a bit of a surprise that when it comes to lifestyle change that will support effective obesity management, they can't do everything at the same time. That's a surprise. And so a metaphor that's been helpful is, sure, you can renovate your whole house, you can renovate the living room, dining room, and kitchen, and bathroom and bedroom and so on. But you know, if you try to do it all at the same time, it's really hard to live in that house. And so supporting the messaging, one thing at a time, one step at a time. The other thing that tends to be really significant, a significant aha moment and a bit of a surprise for them, is that when you've made a change, the process of solidifying and maintaining those gains is not, oh gosh, I've done something for 2 weeks, it's a habit, I'm good. That process takes 2 to 3 months for many changes, even small ones, and that in order to make successful change, every single change that they need to make, you have to go through that entire process. So whether it's eating breakfast or whether it's having more fiber, more fruit in their diet, whether it's carrying a water bottle, they have to go through that entire change for each of those pieces. And the other piece that we know is that patients consistently, and research supports this, underestimate the benefits of change, and they consistently overestimate the cost of change, both not just from a financial perspective, but in terms of an emotional engagement perspective. The third piece, and one of the places where they consistently seem to get caught, is that once they're in phase 4 or 5, then life can throw them off. And that's okay. And that life can throw them off partially or entirely. And that seems to be truly challenging for them. But again, one of those aha moments. So what I've done is I've brought for you a set of worksheets that we use with the patients, and that walks them through some of these processes. And we start with sort of setting priorities, and again, the priority that we might think we have and the priorities that are expressed in terms of our day-to-day lifestyle often are not well correlated. There seems to be often a bit of a mismatch between them. We invite them to consider how many minutes per day they spend focused on their lifestyle specifically. Research, and I believe Dr. Sharma has been quoted as saying that at least 30 minutes a day is necessary, whether it's planning breakfast, whether it's physical activity, there needs to be that amount of focused time. And so we invite them to go through this process in terms of, so what's a priority for me? What do I do to support change? What else can I do to support the change process? And take a look at some of those factors. Often, when we're trying to support a behavior change or a set of behavior changes, then one of the things that we will certainly do is offer patients a number of possibilities where they can get a really quick win. Good success, quick win. And while lifestyle change and weight management is not often a quick win, even if it's an emotional quick win, yes, I can do this, that tends to be really helpful. One of the relatively quick wins we hear about consistently from our patients, and they're surprised, is, gosh, I've started eating breakfast and I've lost 40 pounds in the last 3 months. How does that happen? Right? Or I've started eating breakfast and my sugars have been balanced over the last month, my blood sugars. So again, if we can offer them that kind of quick win, that tends to be helpful, and that tends to be much more motivating. Another one of the challenges that we see consistently is those pesky genes from high school. And secretly, yes, we don't want to get back into those genes in high school, but secretly we want to get back into those genes in high school. And so again, an attempt we try to refocus around not looking backwards, but looking forwards and creating an effective, appropriate, healthy, balanced lifestyle for 4, 5, 10 years, 10 years down the road. For many patients, being able to do this requires going through a fairly significant grieving process in terms of, I can't believe I've been messing up for this long, for this many periods of time. So they need to grieve diets, losses of the secret goal, all of that kind of thing. It's helpful to reframe I want to get back into the jeans that I wore in high school with, you really want to be 15? And it's like, yeah, no, don't want to go there. And so one of the major tools then that we ask our patients to use, and we use consistently, is journaling as a tool. The research tells us that journaling is one of the most effective tools, and we see, certainly with folks who have had bariatric surgery and our post-surgical patients, that when they start to get off track, one of the best ways that they have of getting back on track is to go back to journaling and that kind of thing. It's scary. It's time-consuming. Accountability is challenging. A clear picture is challenging in terms of looking at that. It's also challenging to initiate. We hear consistently about how unreliable it is. The health. We hear our patients saying, "Well, it's almost like I want to keep 2 sets of books, one for my healthcare practitioner, and one for myself." Right, and we hear stories over and over again about patients sort of sitting in the waiting room to see any number of healthcare practitioners with their journals and making it up as they go in. So some of the challenges there are around things like accountability, are around things like sort of having a clear picture, and so what we try to do is minimize the impact of that, both from an emotional perspective and from introducing it into lifestyle perspective. So from an emotional perspective, we suggest that, if you can't look at it, don't. Maybe you want to start with journaling just 1 day a week. Maybe you want to start with journaling just 1 meal at a time. Maybe you want to start with journaling times that are problematic for you from an eating perspective. The other message that seems to really speak to folks, and again, when we look at this population and the we have a fairly significant proportion of folks who tend to think in black and white terms, and so ways to support that is to expand the frame of the journal and to, again, help them focus on things like thoughts and circumstances and those kinds of things, as well as to journal effort, to journal intent as well. So, that piece of cheesecake wasn't on my list. I wasn't supposed to have it, but I really wanted to have 2, and so therefore we can frame that as a success. Go team! I avoided having the second piece of cheesecake, and that kind of reframe of the journaling process tends to be very very helpful. And again, focusing on a clear direction. A number of intervention approaches support the idea of sort of one thing at a time, one step at a time, adding up over time. Then we invite them to make some decisions and consider the their entire life, their entire set of pressures, if you will, before they do that, and go through a decision making process. So, just for a bit of fun, let's say one of the recommendations is that, I order pizza or some kind of pizza every Friday night, and my dietitian has said, you know what, not a good plan. Why might it not be a good plan? Thoughts? Healthcare professionals. Friday night pizza, we want to stop doing that. Why? One of those really double cheese pepperonis. The huge ones.
So it might be too many calories.
Okay, sure.
Nutritionally not balanced.
Too many calories, yeah. So this is a benefit to changing, right? So it's too many calories, so we'll lower the number of calories, yeah. Nutritionally unbalanced, so we want to eat something, so we're crossing it out, right? Nutritionally balanced, yeah. Why else do we want to get rid of that double cheese pepperoni pizza?
I'm just ordering different.
That's, you're jumping to problem solving. Why? So they want to lower the calories, they want it to be nutritionally balanced. Why else? What would be some other reasons why? From a healthcare perspective, we would tell our patients, or they might come to the conclusion, yep, Friday night pizza is not a good plan.
Much sodium?
Sure. So lower sodium. Yeah.
Well, and if they feel tired after eating their pizza, their whole pizza or their half a pizza, if they change that, maybe they'd have more energy to do something else on a Friday night.
Okay, terrific. But we're already there again. Thank you. We're already moving into problem solving and a different phase. So let's just look at.
It's a pattern that you're ordering the same thing every week, and so if you're looking at trying to change patterns or change behaviors, you have to change the patterns.
Okay, absolutely. We're looking to change patterns, but right now, focus on the benefits of not having the physical health benefits of not having Friday night pizza. If that covers it, that's great. Sure. Okay. Go team.
Lower their fat.
Lower fat. Yeah.
Meal preparation.
Okay, we're moving into something else already, and this is the point. To actually make these precise kinds of distinctions is challenging for our patients, absolutely, and can be challenging altogether. Yeah.
I'm also wondering what goes along with that pizza. Is it usually a beer? Is it a bottle of wine?
Yes. Beer. Okay. So we're telling them. Okay. So we're telling our patients, you know what? No more Friday night pizza for you from whichever pizza place you're ordering it, because you can lower your calories, you can eat something nutritionally balanced. My apologies for my chicken scratching here. You can lower your sodium, you can probably save money, you'll lower the fat content, and you won't be tempted to have beer with it. Those are the benefits, right? Now, here are the costs of Friday night pizza, of not doing that anymore, because you know what? Maybe on Friday night, you're tired, and it's easy, right? Maybe it's a family, and we've had some of these kinds of thoughts. Maybe it's a family tradition. Any other things you would have to give up, right? It's a family tradition. Maybe the kids don't complain. Maybe
You don't have to think about it.
don't have to think. Absolutely. The pantry's empty. Absolutely. So it's an easy solution. Don't have to think, right? Maybe the pizza delivery guy has got these gorgeous eyes. That you just, you're tired at the end of the week. Nice to see this handsome fellow with these gorgeous eyes delivering your pizza, right? So I'll call him Luigi. Pick a name, right? I'll call him Luigi. So when with the patients and when we've got them doing a cost-benefit kind of perspective, notice that the benefits, thank you, that's no fun. Here's the cost. It solves these problems for me.
But it also creates other problems because change just does not affect the patient. What about those kids that look forward to that pizza night every Friday night?
Absolutely. Absolutely. So if we're going to help our patients have this change be effective, we have to help them find different solutions to that. Something that doesn't break the tradition, something that the kids will like, something that you still don't have to think isn't fillet of sole with broccoli, I don't know, right? Something that takes all of those things into account. And so then one of the things we look at, and so with your handouts, and you're of course welcome to use these in any way you like, we have patients consider both sides of the fence. The real benefits and the real costs, because short-term change, a short-term pain and long-term gain is a tough pill to swallow. Part of the process is to help them come up with things that will take care of some of those other challenges, if that makes sense. And so again, in the worksheets, we have them go through some of these questions and reinforce the idea that costs and benefits are different. And then we have them speak to that decision and reinforce the notion that motivation is really not a feeling. How many people who, absent various kinds of supports, felt like not smoking on day 4 after they quit? Motivation is a choice, right? As opposed to a feeling. That seems to be revelational, and the notion that challenges are part of the process. And at the time that this particular piece was written, Hillary Clinton was still Secretary of State, which made her one of the most powerful women on the planet. And she equated, at that time, losing weight to global climate change and as being as challenging, complex a process. We invite patients to identify the things that make them comfortable, and the things that don't. The things that don't, we invite them to build on their strengths. One of the challenges that we see consistently is that patients come to the question of weight loss and lifestyle change from a I don't know how to do this perspective. This is too hard, this is too challenging, this is too overwhelming. Our modal average patient is about 48 years old. By that time, you've gone through a lot of things. You've passed parallel parking, you've had perhaps kids, any number of transitions, moves, jobs, changes in your family. And so we invite them to consider some strengths and benefits, some of the strengths and successful change experiences that they've had. That includes actually weight loss experiences as well. Again, reframing it. The challenge with weight gain, if you've had any number of weight loss experiences, has not been that the weight loss has been not successful. Reframing it that the weight gain requires a different, or weight not regaining weight, requires a different set of processes, right? So again, reframing the question of failures and with the quote from Thomas Edison, and the notion that we introduce a problem-solving process. That too is part of your package. Again, we find many of our patients have challenges with this particular process. One of the other significant places where people have challenges is that black and white thinking, the automatic negative thoughts. Some of the more prevalent ones we see is that black and white thinking. If it's not perfect, it's not any good. And we try again, and you're familiar with, I'm sure, the concept of the dial as opposed to a dial or dimmer switch, as opposed to an on-off switch. And we invite them to consider the situations where they've had challenges and go through a process like that. Again, of considering what the trigger is, what their response is, what some alternatives are, what realistic ones that is, and what kind of a plan they may come up with from the future. And so there's an entire CBT process that we use with them for that, and reinforce the idea that their goals need to be both behavioral, and this is again, I'm sure, a message that you've heard before. Surprisingly, it's challenging. We then get them to the point where they're problem solving, and understanding that an initial trial of whatever it is that they're doing is not likely to be 100% successful, and then have them go and practice their lifestyle change. We find that, and the research seems to support that, to the extent that we can tie any kind of weight loss strategies, any kind of weight loss goals to routines that they're already doing, that's going to have a significant impact on how successful they're likely to be. And again, back to journaling. The notion is that journal should become a friend, should become a realistic view, offer a realistic view of what's going on. This is familiar to you, of course. We find that most of our patients have significant challenges in defining a weight loss goal, and defining one that's actually realistic. So yes, I'm going to do 30 minutes of physical activity, even though it's challenging for me to walk for 10, and I'm going to do that every day next week. Or yes, I'm going to, right? They don't give themselves any kind of leeway. We invite them to scale it back. Scale it back from a range perspective, of how extensive they want it to be. We invite them to scale it back in terms of scope and the number of goals. And, we invite them as well. And one of the places where our patients have significant challenges is when they're setting goals. All those shadow goals that they've had in the past come back to bite them, so to speak. It's really tough for them to go, yes, not to carry all that with them. And so we invite them to consider a goal of a time frame of 1 to 2 weeks max. And they seem to be really pleased, and it's with a refocus on effort, and a refocus on away completely from the scale, and refocus on effort and celebrating those lifestyle changes. And then one of the places where we absolutely want them to focus is on the amount of time that they need. So that's the process for them. And these are some of the habits we invite them to use to maintain positive change. Here are some of the strategies we invite them to use in terms of coping with weight regain, the inevitable weight regain, and again focus away from weight loss to lifestyle management. So that said, using the trans-theoretical model from a framework perspective, some of the things that are from the healthcare professional perspective that seem to be that we find are really helpful are things like forging a relationship. That's foundational. In much of the research, the quality of the relationship is more significant in terms of supporting lifestyle change than just about any knowledge or suggestions we can make. We can have all the wonderful research at our backs, but if the relationship doesn't work, that's going to be a challenge. So we want to go through this kind of a process in terms of supplementing the knowledge that they do have, help them identify skills and strengths. That's a challenge. What are you good at? What can you do that has got nothing to do with weight loss? Got nothing to do with this kind of lifestyle change. That seems to be tremendously helpful, and having them consider things like, the relevance and the importance of possibilities and choices. This is why, and again, considering our population, if the numbers are correct, as 70% of them come from significant trauma histories, safety in the context of the relationship is essential. And there will be things that we may do as healthcare practitioners that cause that to come into question. Once we have safety, or once the patient has a perception that this is a safe relationship, then we move through trust and all the way to power, all the way to follow through and patient empowerment. And of course, you're familiar with some of the specific skills that will support the relationship, and the challenges with maintaining change for many of our patients will be to help them identify their calls to action, to help them to help support their self efficacy, and to help them again sort of identify existing skills, existing strengths that they may have. One of the other major challenges that we see with our patient group is the emotional self-regulation. That's tremendously challenging. And so we're doing okay, and then something throws us off. We're not able to regulate our emotions, either because we're thinking in black and white terms, all or nothing. I made a small mistake, that's terrible. Where's the rest of the I might as well go to town, and I'll start again on Monday. I'll start again next month. I'll start again. Gosh, it's in the middle of November. I'll start next year in the beginning of January, right? So that's about challenges with emotional self-regulation. And if you look at the whole concept of relapse, we have to understand that maintaining change is difficult, and we have to help identify things that help maintain the process. So when the patients meet a challenging situation, and the choices are, when they're not able to emotionally self-regulate, when they're not able to just bring their level of arousal, their level of anxiety, their level of black and white thinking down, when they're not able to manage that, then we're likely to get that ineffective coping response, which then leads to that circle of decreased self-efficacy. I can't do this, I'm no good. This doesn't work for me. And it's actually quite remarkable when you look at it. And one of the tools you have is my tool for trapping nets that follows that process from a cognitive behavioral perspective in terms of trigger, response, alternative, and plan. that supports that process. But another thing that you have in your handouts is a practice journal where we invite patients to journal a time of weight management that was successful for them and a time that wasn't. And a small mistake leads to things like thoughts like I'm ineffective, I'm stupid, I'm a loser, I can't do this, and feelings of guilt and remorse and all of that kind of thing. Which then again, I mean, it's easy to see how that would lead to decreased self-efficacy and a higher probability of relapse. In this case, back to an inappropriate or unhealthy eating pattern. So one of the goals would be to help the patients identify what their triggers are for that kind of relapse, and to help them develop contingency plans around that. So how can we help them do that? Frame relapse or reframe relapse as, you know what, most people, before they get to a place where 5 or 10 or however many diets this is really normal in the context of this reference group. This is what's happening, and consider the way that they might be attributing their lapse to. So the challenging situation may be in fact objectively, and most likely is an objectively challenging situation, but gosh, it's my fault. I should have done this, I should have known better. So if we can help them reframe some of those things and normalize that. Another thing that we can do, and I'm sorry if that's not clear enough on your slides, I thought it would be better, but we can look at the purpose of the problem behavior. So if the problem behavior, if we want to look at it from the perspective of, let's say it's having far too much in the way of snacks late in the evening, then we can look at the function of that, right? What problem does this challenging, or the problem behavior, if we want to define it in those terms, what problem does it solve? Does it solve a concern around loneliness? Does it solve a concern around boredom? It has a purpose, it has a function, and if we look at what the function is, then that will help us. So what's the behavior, what events are related to it, the purpose or function of it, and then what interventions can the patient agree to with respect to that particular problem behavior. Again, and the interventions that we would suggest, of course, are lifestyle kinds of interventions. Does that make sense? Okay. So just to wrap up, I'm aware of time. So one of the things I'm just going to invite you to play with a little bit before we leave this piece away. And so this set of worksheets walks you through many of the things that we were talking about, including SMART goals, that kind of thing. But to consider, this is one of the things where my group is working with right now is to look at eating patterns and define them in a number of ways. So if we can consider the eating pattern in terms of, okay, so is this a chaotic kind of problem behavior pattern? In terms of the eating, is it based on context? Is it due to stress, disorganization, that kind of thing? Or is there something deeper that underlies it, right? Because we can look at relapsed or challenging eating behaviors from any of those perspectives, and this is more of a life kind of. I can't organize. Life is too hard. I have ADHD. It's tough to organize things. There's too many things. There's too many things going on, and so I'm just the eating behavior that supports or that challenges weight loss is actually a chaotic piece, and so that would involve one set of interventions. Pardon me. When the eating behavior is motivated with other things, and we see this a lot with some of our young girls, then that's something we need to consider. Or is it an actual diagnosable eating disorder? Is it an actual binge eating disorder? Are there other kinds of things going on? So I brought some for your own reflection and your own if you choose. There's a number of sort of case studies that are just sort of written. There's 3 there. I understand that that may be. I don't know how we're doing for time. If we're okay. Okay. So I'm going to invite you just to play with. Just pick one. There's 3. We don't have time, I don't think, to do 3. But pick one. There are 3 fellows. There's a truck driver. There's a woman who. There's one woman and a retired fellow. And maybe in your tables, at your groups, I would invite you to just think about where you might put these patients from a problem eating behavior perspective, and what supplemental questions might you ask in order to begin to start to intervene. Yeah, question. Totally.
On the previous slide, I was just curious, it says never ask why. And I was just wondering why not? That one.
Oh, all right. So this is about not putting the patient in a place where they're needing to feel judged, defensive, any of that kind of thing. So we would never ask questions about why didn't you do this, or why is that, right?
Not like why is this important to you?
Oh, of course. No, you would want to say why is this important to you. But with respect to challenging behaviors, you would never want to ask them, like, right? No, thank you for that. Does that make sense? So this is with respect to anything that could be challenging, and anything that speaks to the goal of weight loss, lifestyle management, that kind of thing. Terrific. Yeah.
If you guys want to discuss your case studies in groups, it's fine.
Yeah, and please do, and just consider where you might put some of these folks. All right, so if we could just come back, so everyone has had a chance to hopefully just look at that, and so I invite you to consider the problematic eating behavior in any one of those 3 case studies from this perspective, right? So what's the issue? What are the events that are related to it? And perhaps more and most importantly, what's the purpose or function for the patient? What's the purpose or function of that problem behavior? It's a problem behavior from a weight loss, weight management, lifestyle perspective, but it has a purpose or function. It solves another problem that is more salient, more relevant, more important for them. And so then within that context, you can certainly frame that, or here's one frame for it. And I would certainly invite you to consider this as a possibility, or any number of possibilities. This is still very much this conceptualization is still very much in process. So in another couple of months, we'll be able to offer you something that's a little bit more pulled together. But does it fit in any of those kinds of frames? Is it just a question of this is chaotic? Is it motivated by something different? So Penny, Carl, and Alex. Who did Penny? This group? Okay. So how would you frame from a eating behavior perspective? Where would you put her in any of these categories? Which one? Chaotic?
Yeah.
Okay. And so what would the purpose or function of, what problem does her particular eating challenge solve? Stress at work? Okay. Time management? Yeah. Those are challenges. What problem does it solve? We have to dig a little.
Is your eating so?
Yeah. Yeah, absolutely. So we need to dig a little bit deeper. It may be an issue with loneliness. It may be an issue with broader kinds of things. But sometimes digging a little bit deeper to look at what the actual purpose and the function, in terms of maintaining some kind of internal emotional equilibrium, that can be helpful. Terrific. Alex, anybody do Alex? Anybody else do Penny? Perhaps. No. Anybody else? Anybody do Alex? No? Okay, everybody did Carl. Excellent. The folks who did Carl, any thoughts? Chaotic? Yeah. And again, because here, when we say periodic, unhealthy, motivated by aesthetics, those are not and. These are or, right? And these are not and. These are or, right? So in Alex's case, what's the purpose or function? What problem does that particular bit of eating behavior solve? Carl, excuse me. Yes, sorry, Carl. Yeah.
He's trying to make more money.
He's trying to make more money. Yeah.
So his job is very sedentary.
Mm-hmm.
So, and he's a truck driver, so he's probably eating at a lot of truck stops.
Yeah. So we can look at it. Thank you. If we can look at it from that perspective, in terms of, these are some of the concerns. Just objective concerns. It's a financial one, but if I would suggest that if we were to dig deeper with a file like that, we would probably see other things as well. He's feeling lonesome. He's on the road. He doesn't connect with his family. I don't want to take care of myself. I don't know how to take care of myself. There may be other kinds of issues that if we find ways to support, that in terms of what interventions can the patient agree to with respect to the problem behavior. Well, if we can broaden that a little bit and take a little bit of a deeper look at what may be underlying that, then we're more likely to be much more effective. All right, and so I certainly see that I'm past time, so I will say thank you for your attention. I appreciate and the invitation. In the slides you have my number and email. So if you've got any questions, if I can support you with any materials, I'll certainly let you know what happens with our. I'll certainly let you know what happens with our model, and we'll take it from there. So again, thank you. Have a great day. So, go ahead. Totally.
So when you guys look at people and you're looking at all those different stages of making that process to patient empowerment, particularly with patients who've had trauma histories,
Yeah.
how long does it take, and how many visits would you say it takes on average? And I know it's unique to each person, but how long does that process take in your world?
Yeah, it is very individual. It depends on, you know what? It's actually really interesting. It's really interesting because and I'll speak to the question of the patients with significant trauma. The patients with significant early trauma, and this is one of the things we're playing with, significant early trauma they seem to be really refractory to treatment of any sort until you deal with the trauma. Especially, right, the patients that with the earliest sorts of traumas, and they don't have to be sort of significant, sort of 0 to 3. It doesn't have to be sort of significant trauma. I'm redefining sort of significant trauma, but they seem to have the greatest challenge with various kinds of emotional self-regulation. But again, sort of patients that for whom that's not the case. I'll give you a for instance. One lady I was seeing had from about the age of 8 to 13 had been sexually abused. Was very, very heavy. I saw her for 6 months, and done. She's done. We didn't even address the weight issue. We addressed nothing but the trauma. And 6 months, so that's 40 hours of treatment. That's not a lot. If you look at it from that perspective. And all of a sudden the lifestyle turned around, the weight started melting off. I mean, she came in with other comorbidities as well. She came in with depression, she came in with anxiety, she came in with, every time I walk past a flower shop, I have a panic attack. But really that was the core of the issue, and the other stuff. Once that got resolved, the other stuff took care of itself.
So it was nothing, watershed, and then lots of change.
Yes.
Is that a typical pattern that you see?
Yeah, very often. And so in terms of dealing with a weight loss kind of concern, that's one of the reasons why, one of the things that I said earlier was it's really helpful to put in the kinds of supports where you get, and the kinds of goals where you get a lot of early wins. From a weight loss lifestyle management perspective, whatever, because that really helps build confidence, and it sort of gives you food for the road, so to speak, because the road can be a bit longer. Yeah. Does that answer that?
So, I think that's something that certainly I struggle with, is that if you feel like you're doing things for people and there's no movement, and then you get tired, and they get tired, and it's like, okay, what are we doing, right? And so it's interesting to hear that actually that path, that there can then be a watershed and then provoke a change.
Absolutely. Think of it as a plateau. Right? That would be one way to frame it. But one of the things that I'm consistently blown away by, is how little people actually need to do things. If you think about 5 years of significant trauma, 6 months of treatment, that's not a lot. Right? 40 hours of intervention. The other piece that I'm consistently blown away by, and the research supports this, there's no question, but how important the relationship is. How important it is to create safety, to have respect, to create consistency, some amount of predictability, and how important it is, even if you're just focused on something like a health condition, how important it is to maintain that warm, accepting relationship, that warm sort of, right? And again, it has sometimes, that's the major positive relationship in some of these people's lives, right? And so that can be, I mean, we're, as people, we're built for relationship, as opposed to not, and so that has a tremendous impact.
Some of the work in some of the workshops that I've been to around emotional brain training, if you have a provider that is emotionally able to create that safety and that connection with the patient, because a lot of that trauma is laid down in the emotional part of the reptilian part of the brain.
That's right.
Part of the brain.
Yeah.
Is that if you are kind and caring and create that safety and that repetition, that it allows the patient to be able to sit down and do the work, do the therapy in those parts of their brain without creating a full-blown stress response. So otherwise they can't do the work. If you are chaotic and unpredictable, you don't have safety, there's not somebody to hold them, it's kind of like they're let go. That's my understanding of that work.
Absolutely. Yeah, and our brain, we feel faster than we think. Right? We tend to respond to other things. The other piece is, with patients with significant trauma, you can never be sure what's going to be a trigger. Right? Because they can't necessarily be sure what's going to be trigger. It could be a fragrance. It could be the light streaming in a particular way.